Okay, so this will be a friendly talk. You're welcome to interrupt if you have questions. You can ask questions in any language that you want. If the language is not English or Spanish or German, I will not understand you. So many people are familiar with the idea behind the brain-computer interface, so I just have a few slides to review it. A brain-computer interface is a device that enables communication without movement. So most forms of communication, speech and gesture and typing, mice, all require movement. You have to move in some way. When I was at Guttmann last time, Eli was showing me something called a nose mouse that you were using, and you know that many patients can use assistive technologies like the nose mouse or a breathing switch or a cheek muscle switch. But for some patients who have very severe movement disabilities, late-stage Lou Gehrig's disease or ALS or brainstem stroke or other conditions, there may be no way to move at all. So any system, even one that requires only limited movement, is not possible for these types of patients. So a brain-computer interface enables communication with no movement at all. Instead, the system just detects your activity from the brain and sends that onto a communication system. It might be a wheelchair or a speller or another type of system. And so after you acquire the data here and then you send it via signal processing, you can do a lot of things with it. And this has been my background until recently. I was mostly working with BCI for communication. So we did a project a few years ago called Brainable, where we were working together along with another colleague named Philippe Medallas here. And the project was successful, and it was to try to establish communication and control solutions for people. So if somebody wants to control a wheelchair or develop a speller, and ideally someone wants to be able to do that from a real world environment, not just from inside the laboratory, they can do that. That was the goal of Brainable. And recently there have been a lot more applications. So I mentioned spellers, control of an orthosis. A lot of people are looking into games and remote control devices, control of an artificial robot. But these two are showing virtual reality applications that are also getting a lot of attention recently. And so I'll talk about that more toward the end with BCI for stroke. And with coma, most people know, of course, even if you're not medical doctors, that a coma is a very severe state. Persons who were diagnosed with a coma cannot think or perform other tasks, and so, of course, these people would not be able to use a brain-computer interface either. The problem is not simply that they have difficulty moving, it's also that they have cognitive damage that is so severe that they cannot communicate, they can't even think of a message or command. And this figure here shows that coma represents a person with basically no motor response, no reliable control of voluntary movement, and also no indication of cognitive function. So you might apply a test like the Coma Recovery Scale Revised, which I understand that you use here. And from the behavioral response, you see no indication that this person could communicate or could make any decisions. However, persons with coma may often emerge into another state, the vegetative state or the minimally conscious state, in which they may have some improved cognitive ability. So to return to this image here, you see that the motor activity is still quite low in vegetative state or a minimally conscious state. They may still not be able to control a voluntary movement and thereby send a message or a command, but they might have enough cognitive ability. They might be able to hear and make decisions. And this is something we were demonstrating in the morning. So we were here earlier, we met with some of you, and we demonstrated the system called MindBeagle that allows people to communicate even without being able to see or move. And different studies have found that about 17 to 42% of persons who were diagnosed without any conscious awareness do exhibit some indicators of awareness. So this means often the situation is that they have improved since their initial diagnosis, but there's no way to observe that because you're not getting any kind of behavioral response. So you might do items in the CRS scale, for example. You might look for spontaneous speech or see if the patient responds to a stimulus and you see nothing. And therefore, without something like Mind Beagle, you have no other information. You have no way to measure their mental activity. Can they actually hear you, but they can't communicate with you? And so that's what we're trying to work on. So again, persons with coma, if they are correctly diagnosed, they're still in a coma, then a BCI would not be helpful to them. But if they have emerged into a better state where they have some potential for communication, you can use a BCI or a brain-computer interface to reassess them and then potentially provide communication. So this is the Mind Beagle system that we demonstrated this morning. And for those of you who have worked with a brain-computer interface before, maybe if you worked with Eloy, for example, on the earlier project, you see some common components. There's an electrode cap, there's an amplifier, and there's a laptop, and pretty much all BCIs have something like this. But because we have to use non-visual stimuli for these patients, we also have these earbuds that we place in the ears, and then a vibrotactile stimulator here. That's on the side there. It's collecting electrodes mainly from information from the top of the head. And the earbuds are the tactile or the auditory stimuli, and the tactile stimulators go on the wrists. So you can put them on the wrists or wherever you want. Here is what they look like. I'll show that later, never mind. What we're detecting in part is motor imagery. So many people know that you can imagine moving the left hand or the right hand, and this activates motor areas of the brain. And this is what it looks like in a classic motor imagery BCI. You're trying to detect left hand versus right hand movement. And even if you don't actually perform the movement, if you just think about grasping, for example, you see activity in the brain that reflects that you have successfully imagined left or right hand movement. So of course, if you can grasp, if you can move your hands, then there may be no need for a BCI to communicate. You can type or wave, but if you can only imagine movement, you can use that for communication. And you might, for example, think about the left hand for yes and the right hand for no. This is one way that you can communicate, and shortly I'll demonstrate the P300 approach. And we usually find that questions about the patient's background are best. So if you ask about what is your father's name, for example, or what city were you born in, things like this, it can help to get the patient's attention. This is a sample result, and this is an example from a healthy user. So we just got the motor imagery system. We've been mostly working with the P300 approach that we showed this morning. But this demonstrates a nice sort of classic response where you see over the left hand versus the right hand, you have clear activation in one hemisphere or the other. Basically, this area of the brain is right over the somatomotor areas, the areas that respond to touch and that process movement. And Mind Beagle can also use a P300 approach, which can use auditory or tactile stimuli, and I'll show you that. So this is a very easy way to demonstrate the P300. This is a visual version. It's not, those of you that were here this morning, this is a visual version, not like the one that I showed. But this is how most BCIs work if they use the P300. They have a visual display that has maybe all the letters on the screen. And what you ask the subject to do is silently count a certain target letter. So this is a system I've used with many ALS patients. Most of them are able to see, even though they don't have good control of eye movements. They can't all see. But most of them can focus their attention on a certain target. And so you guys can play the P300 game because it's Friday and we have an easy game. So please just notice whenever the P flashes. Whenever you see the P flash, just yell out loud. Say, hey! Say, muy bien. So whenever the P flashes, just say, hey!
Hey!
Hey! So we could play this game all day, and it's tempting. We could just stay here even all weekend. But the point of this is to demonstrate that this is a voluntary task where you choose to pay attention to something. That's the key element, that you think that something is important. So of course you can count anything you want. You can count the A or the I or the J. I don't really know what you're counting, but in this case it's the letter P, so we won't do it again because it's just too much fun. But the point is the computer doesn't know what you're trying to communicate. So what it does is after each flash it looks at the resulting brain activity, and it's looking for something called the P300, which is over there, the big bump. What this is a positive change in the EEG, a positive change in your brain's voltage that occurs about 300 milliseconds after an event. So if the event is a flash, you get this only if you're paying attention to the flash. So if you ignore the flash, you see the P300 doesn't really appear, but if you were silently counting it, or you're yelling hey, or any task, then you get a different brainwave. And so this is how you can communicate with the brain-computer interface. You could use motor imagery, there are different signals, but a very common approach is like this. You flash, usually they're not individual letters, but you group them in rows or columns so that it's faster, and you tell someone to count whenever you hit the target letter, and usually you get a clear P300 only when you flash that letter, and as a result, the computer says, okay, well, we see this brain signal whenever we flash a certain letter, and so we'll just put that on the screen, and you do that a few times and you've spelled a word. And so I'm not going to talk about it much today because I'm mainly talking about MindBeagle for communication, which doesn't use visual stimuli. This is just to show you an example of this. But also, as a side note, I was talking with Eloy a little bit about patients in a locked-in state, and that's who I've been working with for almost 20 years for BCIs. It's only recently that I started working with a broader variety of patients, like minimally conscious and stroke. So most of the people I worked with are late-stage ALS, and the system works for them, so it does provide communication. So I think Eloy knows about it and is familiar with it. But we just had a new partner in Italy who started using it with patients there, and they're getting the same result. They say, yes, it can provide communication, and their main thing is how do you make it faster. There are various ways to make it faster, but they're not worried about basic technical problems. And we did a demo this morning with MindBeagle. I'll get to that, and it worked. So this is the vibrotactile stimulator that's connected to the wrist. So when you're working with patients, we would tape them to the wrist. In the demo this morning, you can just have people hold them. All that matters is these vibrotactile stimulators are creating something that you can pay attention to, that you can count. In this case, the event is a little feeling on your wrist. It just goes zzz. So it's not an electrical stimulator. It doesn't pass a current through the wrist. It doesn't hurt. It just vibrates. So, of course, most of you don't know me, but there are colleagues here who tried it, and they say, yeah, it's easy. It's not a painful or unpleasant stimulus, but it's certainly enough that you can detect it. And so the patient's task is to silently count whenever you stimulate one wrist or the other wrist. So, for example, we say the right wrist. So imagine that you have these little things that vibrate periodically, so you feel zzz, 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 zzz. And whenever you feel a vibration, you silently count it. It's the same thing as yelling out hey, but of course these people can't speak, so you use silent counting as a task. Whenever they silently count, you see this bump, this brainwave called the P300, develop, but when they ignore the stimuli, you see nothing. So this is the same thing we saw this morning with developing a nice P3 with a healthy person, of course, but it was developing a nice P3 only to the target stimulus. And we also tried it with tones. There's a version with auditory stimuli, with earbuds, and you play a series of different tones, a low-pitched tone and a high-pitched tone. So it's like boop, 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 beep. And you tell them to silently count the high-pitched tone, and this will give you this brainwave only if they're able to follow the instructions. So what that does is it provides a way to assess or reassess patients. Instead of having to use, for example, an fMRI or a more elaborate method, You can use this to determine if people are able to understand you. Can they choose to count a certain stimulus? Are they able to remember long enough to do the task? Can they pay attention? So for you or me to do the task is relatively easy, but for a patient with severe damage that could affect different cognitive functions and also attentional functions, it's actually showing you kind of a lot in terms of what spared function they have. And we have different tests that we were showing this morning that can go along this hierarchy of function, meaning that you can start out by testing very basic detection of tones. Can people notice that something is different? And then you can move up to using this approach for more advanced testing and also for communication. So the way that you would use this for communication, like I was saying before, it's pretty similar to the assessment. You just have these tactors that are active in the left or the right, and then you can tell someone that if you count the left hand, that means yes, and the right hand, that means no, and then you can start asking them yes or no questions. And this is also in the protocol that I'll send you that we were discussing, that one of the things we do also to test the system is we simply ask questions like I was mentioning before. Is your father named Mario? Were you born in Rome? Did you go to high school in France? Things like this, because then we can tell from the yes or no that the system is working, they can communicate, and then you might go on to other questions where you don't know the answer. Are you too cold? Do you want a different room? Do you want to try rehabilitation therapy? Of course, you might even ask about end-of-life decisions. So in Italy, they were very concerned about that. And in theory, you can ask any type of question. So we're working on more advanced questions. Right now, we only have yes or no or skip the question. So we have a variant where we have three tactors, three different stimuli. So that lets you say three things, either yes or no or skip. So we don't have it yet, we won't have it for several months, but we're working on new things where we have, for example, a belt that you can wear that allows you more different distinct stimuli, or maybe a bracelet on your wrist or a neck device. We saw a colleague in the United States, and she had a device with 12 stimulators around the neck, and so you can feel if it's stimulating here or here, and maybe you could get more advanced control, but right now we don't have that. So this is the vibrotactile stimulator that we showed this morning. It's basically not a big deal technically. It's pretty easy to stimulate. This is a common trick that people use when they're kids. They put this little thing on their wrist and they shake your hand and it goes zzz, and say, ah, you got me. Okay, so in the next 6 slides, I'm going to show 3 different participants. And the reason I chose these 3 is I wanted to show a continuum of different responses. The first one is with a healthy person, and so this is just to show that it works with healthy people. We found the same this morning, so we're happy to say that one of your neurologists who we tested is conscious, did have conscious awareness this morning. Good job, congrats. So it's fun doing these demos because if you're in a room with neurologists and it shows that a doctor is not conscious, you can't explain that. You can't say, no, it's his fault, he's not doing the task. If you're not conscious in this demonstration, it would really have been embarrassing for us, but that didn't happen. So we got good accuracy. And if you just look on the far side there, on your right side, you notice that the red line, which is the P3, is very distinct. There's a large, clear P300, and the red line is for target stimuli, and the blue line is for non-target stimuli. So for now, I'm just focusing on these tasks. There are also verbal tasks that you can do, but just the P300 one, which we demonstrated today, you see that there's a very robust difference between these two. And so just from looking at that with the human eye, you should think, well, that must be easy to classify because I can see it. It looks pretty obvious. So this next slide will show the accuracy that we got with this healthy person. And you see that the accuracy there very quickly goes up to 100%. So often with the P300, the first time, the very first pulse, the first time it goes zzz, you often don't get 100% because you have to average together a few of them to get a good signal. This is common with the visual ones also. It often takes, say, three stimuli. And so with visual or auditory or tactile, this is a fairly common result. So if we get anything different, if a healthy person does not show high accuracy, then that basically means the system doesn't work, or the person wasn't doing the task for some reason, then I would have been mad at you, but that's not what happened. All right, so that's the first person. There's nothing surprising there. So we didn't learn anything from this. We already knew that he was awake. But now here is a person, this is an MCS patient, and he had a traumatic brain injury, and you see the CRS-R value is 8. So this person got a score on the coma recovery scale that is consistent with a minimally conscious state. The person had very little ability to move or respond to test instructions. And you notice that if you look over on the P3, the difference is much less obvious. And this is what you see in the literature with the P3, which is also used in clinical assessment, that it tends to reflect cognitive ability. Persons with dementia, with Alzheimer's disease, with various kinds of injuries usually have a smaller P3. In fact, that could be something for a grant proposal, but we can get into that later. Also, depressants make it smaller. So they've done studies with alcohol, benzodiazepines, marijuana, any kind of anesthetic drug. They've also used this as a tool for detection of awareness during surgery. So if someone is anesthetized, you can also, if they have a P300, that means they're awake, they're processing stimuli, therefore the global anesthetic is not working that well. They maybe want to do something about that. But it's a commonly used tool. So in this case, it indicates the person does seem to have some brain damage, but there is enough of a difference the computer can detect. And so the next slide shows what you get from 2 different runs. And this is showing that it takes more stimuli, but you can get up to 100% accuracy. What that basically means is that it would be relatively slow. Instead of a healthy person where you could just have a few stimuli, you might need to do it, say, 10 times. You go zzz, 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 10 times in total, meaning you can still communicate, at a reasonable rate, enough that you can ask yes or no a few times per minute, but not as quickly as a healthy person could use it. And then I wanted to put up another result just to emphasize what I was saying earlier, which is that a lot of patients will, of course, not exhibit any conscious awareness. And this was a patient who was in a vegetative state. It was also a male person with traumatic brain injury. But you see the CRS-R score was a little bit lower. It was only a 6 instead of an 8. And the P3 really doesn't look like much of anything. And this is also what the classifier found. So you see the accuracy is very low. In this task, the average accuracy by chance is 12.5% because there are 8 vibrations going to the wrists. And so you see it's about chance accuracy. You actually did get a nice response there over one channel, but it wasn't really reliable. And part of why I wanted to show this is that if you are some of the people who work with MindBeagle, if you get a response indicating that someone cannot communicate, this doesn't necessarily mean that the patient is permanently unaware. It doesn't mean the system is not working. It just might mean the system is correctly detecting the brain waves this person produces while he or she doesn't do the task. So if the person cannot do the task, the EEG will reveal that there is no indicator of conscious awareness. But it also indicates something else that we were discussing this morning, which is that people may not be responsive during one session for different reasons. So, of course, they may only be conscious at some time. So patients with MCS may sort of be conscious and not conscious. It's hard to know when they're awake or alert and able to respond. And we had a patient just a couple weeks ago who fell asleep while we were collecting data, and we could clearly see right when it happened. The beginning, it looked really good. The accuracy was up to over 80%. And then right after the patient went to sleep, it went down. And we tried another run anyway with the same patient just to see, but it didn't work. So one of the things that we were discussing is that you rarely want to assess somebody just one time or even 2 times. If you get no result, you might want to try again, just because, you know, maybe they were asleep, they were fatigued, they were not motivated. It's possible they didn't understand the task the first time you explained it to them. And we have this in our protocol also. We have instructions where we try to be very clear about what the task is. We try to choose questions where it's really obvious, so everybody knows if someone can only say yes or no, make sure it's a question that you can answer with a yes or a no. So to summarize this part, and then I'll talk about the new system for stroke. Many persons are diagnosed, and in some cases misdiagnosed, as having no conscious awareness. So again, the common cause is that someone might have not been conscious during an initial assessment or improved after the initial assessment. But of course, it's always possible that when they did the assessment initially, there was a problem with the equipment, someone made a mistake. The example of that we're thinking about too is this might also be useful for low resource areas where you never have the chance of a proper assessment in the first place. So here you live in a region where if you had a traumatic brain injury, you could get to an MRI, you could get to not just a medical doctor, but a neurologist who specializes in this. But this is something for later on. It's not something we're pushing with the Guttmann Institute. But we have a partner in China that we're working with who wants to explore it in the mountains in western China. And he says he grew up there, and that if somebody has an accident there, they often don't see a doctor, they have no diagnostic ability. So it might be useful there too. And BCIs could provide reassessment and communication. So the first thing that you want to do with this system, and this is what I guess you'll start testing further with it soon, the first thing is to see if they have any conscious awareness. So there's no point trying to communicate with a patient who cannot hear you or doesn't understand or doesn't have enough memory to do the task. So that's why we have assessment first. You want to first do this assessment, which takes a few minutes. So we showed it this morning. It's not a really long thing. And there are different tests that can assess different levels of mental ability. So you can assess, for example, do they have the ability to notice one tone that's different from other tones? Can they shift attention from left to right? These are all things that are important for a re-diagnosis, but if they can't do these things, then there's no point in trying to communicate. Yes, there's room right in the middle. And EEG activity can vary greatly across sessions, so I think you already know this, but yeah, like I said, one session they might be asleep, another session they're relatively alert. And at this point, I'm going to go to the second part of my talk with the new material for stroke. But first, I wanted to see if you have any questions about what I showed so far. And I'll be here after the talk, of course, to handle questions. And I do realize I'm competing with both traffic and a weekend, so don't worry, I will not talk so long. I think that I'm interesting, but I'm not as interesting as going home for the weekend. And it's a nice day, it's sunny. So, okay, this part, I lied. This is not interesting because you know that already. So stroke can lead to movement impairment. Yes, we know. But, so in physiotherapy, what you often do is you can ask users to perform specific movements while imagining them. So some persons who have a stroke have partial ability to perform movements, but some of them can no longer perform a movement. So one example we work with a lot is wrist dorsiflexion. So many people simply cannot raise their wrist, and if you ask them to raise their wrist, they can't do it at all. Some people can maybe do it a little bit, and with healthy people you can do it more. And this is a common enough thing, and it's on the Fugl-Meyer test, and people do physiotherapy for it fairly often. So what physiotherapists might do is they will manually help someone perform a movement after you ask the patient to imagine the movement. So say, okay, I know you can't move your wrist, but just try to think about lifting your wrist. And then the therapist will manually lift the wrist. Or sometimes you use functional electrical stimulators. You put these fast pads here and here That stimulates the muscle, it causes the wrist to lift. The basic problem with that is that it's a type of feedback in which you're doing feedback without knowing if the patient is actually performing the task, right? So a physiotherapist can ask someone to imagine moving, but you have no objective way to verify if they're performing that movement imagination, right? If they can move their wrist, then you can objectively verify it. You can see it, you can put an EMG sensor or a position sensor, but if you have none of those opportunities, then how do you know if the person is actually thinking about wrist movement? And so this is essentially what got us thinking about it from a BCI perspective. There's no objective way to measure that. And so what this system is doing is providing that objective mechanism. That is, you have an electrode cap, and with the electrode cap, you send the data on for signal processing, like the slide I showed very early. But the new part, the thing that differs from conventional physiotherapy, is that the feedback that's provided, such as from a monitor or an FES, is only active if the person imagines movement, right? So the electrode cap is there to detect the movement imagery. I mentioned earlier that if people think about moving the left hand or the right hand, then you can clearly see the difference in the EEG. Is it left or right? And if they think about moving the feet or the legs, that's more right in the middle of the head. And so that's what you're getting toward right here. You have a system that can detect whether someone is thinking about moving the left or the right wrist, or the left or the right hand, and you use that so that they only receive video feedback, which is, you can watch a monitor with hands. The video feedback only occurs if they actually imagine that movement. So if you think about, for example, grasping, then the left hand on that monitor will grasp. Or if you think about doing this, then the left hand will move up. It will dorsiflex the left wrist. And so this is a closed loop feedback system where the patients are only getting this feedback for the movement that they're imagining. So a patient might not perform the movement imagery for a lot of reasons. Maybe they don't understand, or maybe they're not responsive at that time. It could be an issue with motivation or depression. Another common thing when I talk about this with physiotherapists is they say that patients will try to do what you tell them, but they use a compensatory strategy. So instead of moving the arm, they try to move the elbow or the shoulder in some way, and they're trying to help you, but of course that's not what you want. What you really want is that the feedback that they get is occurring only when they imagine the movement. You're trying to basically strengthen the neurons in the brain responsible for that movement, and you're trying to do that by reestablishing this connection to the physical movement. And so that's what you're doing here, is you're essentially providing a closed loop feedback. You're providing a way that the feedback only occurs when they're imagining movement like they're supposed to. And the feedback with the optional FES, this is what we will have here hopefully next month. So we're looking at returning, because we have this new system that has FES. I mean, we've had it for a while, we've been testing it and stuff, but we will have an extra one soon. And so with FES, they only see their wrist move if they imagine movement. So the FES, for those of you who haven't used it, it just sends a current here through the wrist extensor muscles that will cause the wrist to move. So if you have damage in the brain, such as from stroke or traumatic brain injury, you might still be able to think about the movement. In fact, you typically can. You can imagine moving. You just can't cause these muscles to activate with your brain. This way you can. So you think about moving, and that causes the muscles to activate, but it doesn't do it directly. It's not because you think about it, the signal goes down the spinal cord and it goes to the muscles. Instead, you think about it, the signal goes to the electrode cap goes to the computer controls this muscle, but that can still cause this dorsiflexion. So at this point, I'm going to just pause the presentation to show I'll show this video first, and then I'll show another one. So here is a video, and this is a video with the Recoverix system with a colleague in Romania. And you see that the hand movements there are being caused by the fess, so that it's the stimulation that causes that to happen. And you can also see a bar that goes, it's kind of hard to see. And what that reflects is the strength of the movement imagery. Now we have an avatar, but this was a year ago. And so you see that if the person thinks about moving the left hand, a bar goes to the left, and now it's going to be the right hand. So you see this blue bar is going to the right, and at the same time, the person's right hand is active. And so this is, I'll keep it playing while I'm talking over it. So this is something that is new, that you're using a brain-computer interface where the goal is not to say yes or no or other things. The goal is to control your arm.
Is this a stroke patient?
Yes, this is a stroke patient. Mm-hmm. So I have a few slides later on that I'll show where I give examples of stroke patients and what happened. And so also this is an older electrode cap. So we used to record from 45 or 64 channels because we wanted to learn what channels matter. Now we just use 16 channels. So in the system that we want to bring here, if you get ethical approval and if everything works and you're interested, we have a system that's only 16 channels, and the other big improvement, like I was saying, is that it has a real avatar. So the visual feedback is not a bar that moves to the left or right, it's the actual movement of the wrist. And this is also an open question. So Recoverix is of course a new system. What you saw there was a prototype. We haven't proven that this visual feedback is better than just watching your own hand move or seeing a bar move or hearing tones. Nobody knows that yet. People know that the immersive avatar is effective, and this is actually a group in Barcelona that we work with named Mel Slater, who works at the University of Barcelona, has done a lot of work with virtual avatars and feedback for stroke patients. And also, I guess you're friends with this guy I mentioned before, Philippe Medallas, who works at Oidecat, and they also are interested in this, the best ways to really provide feedback. But we don't know, it might be better to just have your own arm that's moving. So I'll show some of this, and then as I mentioned, I have another short video. This is an example of one of the patients we worked with the prototype system. So this is in 2014. It's a person from Romania, and the guy had a stroke, he was right-handed, and this here shows the performance on the 9-hole peg test with the right hand. So many people have seen the 9-hole peg test, but some of you haven't. It's a test, where you take pegs, you have to put them in holes. So for healthy people, just like this person with the left hand, it takes very roughly 30 seconds to do the test. There's some variety, but that's what we were getting here. So it tends to be a little bit longer for persons who are older. They take a little longer to do the task. Men take a little bit longer than women to do the task. I'm not even going to get into that one. But you see in this case with the right hand, this person started out pretty bad. It took more than 1 minute to do the task. And he used the Recoverix system from about June until about September. And then you see they did a follow-up run a few months later, and their performance with the right hand was about normal. So the results that I'm presenting here, again, this is a new system. So what we don't have and what we're just starting is a large-scale clinical trial. So I can't say for certain that this is a better result than he would have had if he got conventional physiotherapy instead. But it does at least validate the system. It shows that it works, it can provide improvement. And so again, this is what we might start doing with you if you're interested, is working with this with a larger controlled study. And I'm just curious, is anyone here a physiotherapist? Any physiotherapists here?
Occupational therapist.
Two? Yeah, or occupational therapist, cool. Yeah, so I might want to talk to you more later about all this. So GTEC actually has been hiring new types of people. We hired a physiotherapist who's been helping with all of this, the system design, and it's fun to be working with a new patient group, basically, with a new application. So again, like I was saying before with MindBeagle, this is a new goal. The goal is not really to provide communication, the goal is rehabilitation. The goal is to help them regain motor function more quickly than they would otherwise. And here, I'm not going to go into too much detail with these slides because I know it's an audience that's more medical and not engineering. But one interesting thing here, this is basically showing you the experience from the computer's point of view, which, you know, we care more about the patients, but the computer cares about whether it can separate left-hand movement and right-hand movement, and you see that they can. So here is the first session, and you see the blue line and the green line, which reflect left hand and right hand, look almost identical. There's no real difference there. And at the end, after training, the blue and the green lines look separate. So that means the computer was able to separate left movement going out to the left and right movement going off to the right. And this is not just our work. So there have been a few studies. One of them was from another hospital, the Santa Lucia Foundation in Rome, and they were finding that this tends to occur with this kind of training. That if you train people with a brain-computer interface that controls a FES system, you tend to see a clearer separation of left and right hand, which is consistent with improved recovery from stroke. And also, if any of you want any of these papers or anything, please just email me. I have my email address at the end, or I'm happy to talk to you. But I have, you know, numerous papers that I can send, not just from us, but from other people. And this is an interesting patient because she already completed conventional therapy several years ago. So this person had a stroke in 2010, and she was unable to move her left hand. So she was an example where this hand couldn't move at all. And after conventional therapy in 2010, she still could not move her left hand. So that was the end of her experience with therapy. And then 4 years later, she came and saw this brain-computer interface system and decided to use it. And so it's interesting for two reasons. First, this is the only patient we had who was in that timing system where first she did conventional therapy, then we had a gap, then she did this kind of therapy. And it's also interesting because this is well into the chronic state. So 4 years after the stroke, it's not to say that physiotherapy is useless, but usually physiotherapy is recommended more in the subacute stage when people are more able to respond. So in a sense, we had a disadvantage relative to the conventional therapy. She did that right after the stroke, and then 4 years later, we tried this. And so after 10 sessions, she got some ability to move her hand. We never did the 9-hole peg test with her because she was never sufficiently recovered, but this is showing a case where the Recoverix system worked when prior therapy efforts did not, even in the chronic state. And this is another thing I guess we can talk about more later. We have different kinds of testing partners. So this Recoverix project, we just got new funding to do larger scale tests that just started in early February. And so we're finding that we kind of get two kinds of people. One of them is dealing with patients usually in the subacute stage right after they have a stroke, in which case they have to give the patients conventional therapy for ethical reasons, but then they can also do Recoverix therapy. And then the second type that we're getting are examples like this person where they work with people who have completed conventional therapy already. So they did conventional therapy, it didn't provide full movement restoration, then they want to try something later on, which is kind of scientifically different. Then they do one kind of therapy and then they do a different kind of therapy. So we're open to work with those because I know you have basically all kinds of patients, but you have some subacute and then some who are here in the longer term for rehabilitation. So I just have a few more examples and then I'm done. So this is showing, similar to before, that this woman who at the beginning, the left and right brain activity look very similar. So when the classifier is trying to figure out, is she thinking about doing this movement or that movement, the classifier can't do it. And by the end, it's pretty good. And this is another example of someone, so we've worked with a total of, I think, 6 patients so far with the Recoverix system prototype. So again, it's a new system. We're just using it now. And this person, we also couldn't do the 9-hole peg test because the right hand was paralyzed. But you see in there, the class separation wasn't much better, but the thumb and finger movement improved. So they were doing a Fugelmeyer upper extremity, and they also had a, I forgot the name of it, but they had another test that I can find out that was specific to finger activity. And this is another person, and gained the ability to move the hand from about the stomach all the way up to the mouth. That was pretty good. And so the interesting new finding that we have is that functional improvement does not require a high classification accuracy, right? So what this means is that, let's say for a communication system, they would only get maybe 80 or 90% or even 70%. With yes, no questions, that can be kind of frustrating, but we find that the therapy still is providing improvement. They're still getting the feedback fairly often. And so we're still looking at that. That's a new observation. So I'll go on to my summary, and then I'm done. So conventional therapy relies on feedback that may not be paired with motor imagery. That is, people might be told to imagine the movement, but they might not be doing it for various reasons. And so BCIs can monitor the EEG to add a real-time measure of motor imagery. It can tell you without any delay. So in true real time, there's no real processing delay. It can say, this person is thinking about left-hand movement, and then you might, for example, activate the left fess, or you might take other activities that would improve the physiotherapy loop. And in non-real time, it's also just useful for assessing compliance. So if you see day after day that a person is not performing the required motor imagery, then you can say, hey, why are you doing that? You gotta work harder. And we need further work to show that it's better than conventional methods. So again, it's still something we're developing now, but it's good enough that we wanted to talk to you about it and maybe work with you on it. And so I first am of course grateful to Eloy for setting up the talk and for hosting us. And these are a couple locations where you can find more information about it. And the last thing to say is that on the GTech webpage, we have webinars. So if you can email me too, or just go to GTech and type webinars. We have a lot of webinars that last 1 hour. They're free. They're similar to the talk that I just gave, but we also have a live demo. So any of you can come, I give my talk, and then we have a demo. So you can say, okay, I want to show that the system works, tell them to imagine the left hand, and you can see the left hand activates, and it provides a different way to help show how the system works, how long it takes to set up, which we did it today, it's only a few minutes, and other such things. So that's it for my talk, and I think we have a little time for questions, right, Eloy? All right, yeah, question time. Yeah.
Using rhetorics, can you position the phaser in every part of the body you want, or you are intended only for wrist extension?
Good question. That's still in development. So right now, all we've been doing testing with so far is wrist extension. We now have, in addition, elbow extension, knee extension, and there's one more that they're working on, and those just became available in the last few weeks, so we just started doing that. This is another thing to possibly discuss with you, is if you want to try other types of movements. One good thing about Guttmann is you have access to patients with lower limb disabilities in addition to upper limb. So yeah, we don't have it, we want to start using it. So the FES pads themselves, they just work anywhere. So you can put the pads here in the back of the knee. We have 2 different pad sizes. So the only cause of the delay was developing the new avatars and then testing it to make sure it's safe. So I think we'll be back in a month or 6 weeks, somewhere around there. And so if anybody wants, I'm happy to visit with people and we can talk about, if you're interested, what kind of patients you work with, what protocols you would be interested in doing, what kinds of things you want from us. So we can try to develop things around you guys.
Just one question for me. Related as well to the recoveries.
Mhm.
You said that you are gathering data to somehow make the evidence that this is effective compared to conventional therapy.
Right.
But and you want us to become one of the partners to collaborate in this trial. But I thought that there were some evidence already in the literature conveying that this therapy,
Mhm.
combining FAS and motor imagery is effective.
Yes,
Is
they're both true. So there have been several papers published, and there's a lot of data, like I showed you, that shows that this approach is more effective. I meant that we haven't proven it in this, and nobody has, with a large-scale clinical trial. So the reason I mention that is just for billing reasons and practical reasons. At this point, we can't honestly say that we've clinically proven, or anyone has clinically proven, that it's better, because the papers are with a dozen patients or 20 patients or something, and they come from different groups. So it doesn't have a clinical trial where you have a much larger number of subjects. But yes, there have been papers that have said that we compared this approach with BCI and a functional electrical stimulator to something else, or to a sham therapy where you just don't turn the amplifier on, and the BCI therapy is better. So yeah, it's not that unproven. It's not like we just had this crazy idea, but there hasn't been a clinical trial.
Thank you very much.
Okay, thank you.
Very interesting.